We're diving into something today that's really shifted how we think about strength and vulnerability. Let's start with Simone Biles, maybe the greatest gymnast ever,
Right.
at the Tokyo Olympics. She made headlines everywhere, not just for, being amazing, but because she stepped back,
Yeah.
pulled out of competition to focus on her mental health.
That was such a pivotal moment, wasn't it?
Right.
Really helped fight the stigma.
Yeah.
I mean, here's the Juet saying outright she deals with anxiety, she gets psychotherapeutic help. It just showed so powerfully that, well, psychological suffering can affect anyone. Doesn't matter how successful or physically strong you are.
And that shared experience, that's really our focus today. We want to explore the different scientific ways we try to prevent and treat psychological suffering. Looking at the psychological, the biological, and the sociocultural angles, it's a pretty big landscape.
It is, yeah. But if you boil it down, there are really two main types of treatment. First, you've got psychotherapy.
Often called talk therapy, right?
Exactly. It's a non-medical approach. Uses strategies like talking, interpreting, sometimes rewarding behaviors, modeling, all aimed at helping people overcome problems, reach their goals.
Okay, and the second type?
That's biological or biomedical therapies. These come from the medical model. Think medication or sometimes physical procedures. The goal is to change how the body functions to reduce symptoms.
Got it. So who does what? There's a difference in the professionals involved, isn't there?
Definitely. You have clinical psychologists. They typically earn a PhD or a CSID. That's 5 to 7 years of focused training. Could be clinical practice, research, or both. They're the ones providing psychotherapy.
And then there are psychiatrists?
Right. They're medical doctors, MDs. They go through medical school and a psychiatric residency. It's a longer path, maybe 7 to 9 years total. And critically, they are licensed to prescribe medications.
And that's where the big debate comes in, isn't it? Should psychologists be allowed to prescribe meds?
Precisely. It's a long-standing controversy. People who support it say it would improve efficiency. Yeah. Especially, in rural places where there aren't enough doctors.
Makes sense.
They also argue that since psychologists' first instinct is usually therapy, maybe they'd be less quick to jump to powerful drugs.
Okay, but there's a flip side, a pretty serious one. Psychoactive drugs are powerful. They affect your whole body, not just your brain.
That's the main counter-argument. Critics worry that the extra medical training proposed for psychologists just isn't enough to manage these complex medications safely.
And they might miss something, right? Like a physical illness that looks like a mental health issue.
Exactly. That's a major concern. What's the right balance of care? It's tough.
So where does it stand now?
As of now, it's still very limited. Only a few states in the U.S., I think Idaho, Illinois, Iowa, Louisiana, New Mexico, allow psychologists to prescribe, and only after they complete significant additional medical training. It shows how carefully that line is being managed.
Okay, let's dig into that first pillar then. Psychotherapy. The big question everyone has is, does it actually work?
Well, based on tons of research meta-analyses looking at hundreds of studies, the answer is a pretty clear yes.
Really?
Yeah. If you commit to therapy, say around 12 to 14 sessions, you're much more likely to see improvement than someone who gets no treatment. And often, those improvements last for quite a while, like 2 or 3 years.
Wow.
And that holds true even for therapy delivered remotely, which, as you know, has exploded recently.
Okay, but there are so many different kinds of therapy out there, all these different brands. Is there one that's just better, the magic bullet?
That's where it gets interesting and debated. Generally speaking, the research suggests that no single type of therapy is dramatically more effective than others across the board. For a while, there was a push for what's called empirically supported treatment, or EST. It's kind of like a medical prescription. If you have disorder X, you get treatment Y.
That sounds a bit rigid, like it doesn't account for the person.
Exactly. It felt too mechanical for many. So the field has largely moved towards evidence-based practice, or EBP.
Okay, what's the difference?
EBP is more of a balance. It says treatment decisions should integrate 3 things. 1, the best available research evidence. 2, the therapist's own clinical judgment and expertise. And 3, crucially, the client's own characteristics, their culture, and their preferences.
So it brings the client back into the equation.
Absolutely.
Yeah.
It sees therapy as both a science and an art, tailored to the individual.
That makes sense. So if it's not just the type of therapy, what does make it work? Are there common factors?
Yes, definitely. And this is really insightful. 3 things consistently pop up. First, the therapeutic alliance.
The relationship.
Exactly. That trusting cooperative bond between you and your therapist.
Yeah.
If that alliance is poor, people are much more likely to drop out early. It's foundational.
Okay, what else?
Second is the therapists themselves. It's less about the specific technique manual they follow and more about their individual skill, their genuineness, their empathy. That fit between therapist and client is really important.
Right. And the third,
This one might surprise you. It's the client.
me, the person in therapy.
Yes, you. The research strongly suggests that your participation, your motivation, how willing you are to engage and use what you learn, drawing on your own strengths, that's actually the single biggest factor in determining whether therapy is successful.
Wow. So it's not just something done to you.
Not at all. As one review basically said, the client is the one who makes the therapy work.
That's empowering. And you mentioned something about predicting that alliance early on.
Yeah, fascinating study. Researchers looked at acoustic markers in people's voices, things like how often they paused, and something called jitter,
Jitter. What's that?
like tiny brief disruptions in the vocal sound. Often indicates distress or nervousness. They analyzed just the first 10 things people said in their initial intake interviews for depression therapy. And they found that more pauses and more jitters right at the beginning predicted a weaker therapeutic alliance later on.
Incredible. Just from the sound of their voice in the first few sentences.
Yeah, it suggests those subtle vocal cues can reveal a lot about someone's readiness or capacity to connect, even before you get deep into assessments.
So if that connection is so vital, let's look at how the main approaches try to build it. You said therapies differ in a couple of ways.
Right. Generally, we can think about whether they focus more on gaining insight versus developing symptom skills, and whether the therapist is more directive, telling you what to do, versus non-directive.
Got it. Let's start with the classic one.
Okay, psychodynamic therapies. These come straight from Freud and his followers. Big focus on the unconscious mind, how early childhood shapes you, and lots of interpretation from the therapist.
The goal being insight, right? Understanding those hidden conflicts.
Exactly. Techniques you might know are free association. Just say whatever pops into your head, and dream analysis.
And that concept of transference.
Oh, absolutely key. That's when you, the client, start relating to the therapist in ways that echo important past relationships. Maybe you see them as a critical parent or an unavailable partner. Working through that transference is a major part of the therapy.
Okay, moving on. What's next?
A total shift. Humanistic therapies. If psychodynamic looks back, humanistic looks at the here and now. It emphasizes your capacity for self-healing, conscious thoughts, and personal growth. Carl Rogers and his client-centered therapy are the big names here.
Rogers had those core conditions, didn't he?
He did. 3 essential elements he believed the therapist must provide for growth to happen. Unconditional positive regard, basically, accepting you fully, without judgment.
Okay.
Empathy, really trying to understand your world from your perspective. And genuineness, the therapist being real and authentic in the relationship, is very non-directive. The client leads the way.
Right, so less interpretation, more support and understanding.
You got it. Now let's switch gears completely again. Behavior therapies.
These sound more action-focused.
Totally action-oriented. Forget insight, that's irrelevant here. They use principles of learning classical and operant conditioning to change specific maladaptive behaviors. It's all about observable actions and symptoms.
Okay, like what kind of techniques?
Well, using classical conditioning for something like a phobia, you have systematic desensitization. You learn deep relaxation techniques, and then you gradually confront a hierarchy of anxiety-provoking situations. Maybe starting with just thinking about the feared object, all the way up to facing it.
I've heard of that, like for fear of flying or public speaking.
Exactly. Then there's aversive conditioning, which is less common now. That pairs an unwanted behavior, like excessive drinking, with something unpleasant, like a nausea-inducing drug, to make the behavior less appealing.
Ooh, sounds intense.
It can be.
Yeah.
On the operant conditioning side, you have things like applied behavior analysis, ABA. That focuses on reinforcing desired behaviors and reducing unwanted ones, often used with developmental disorders, for example.
Okay, very practical, very focused on changing what you do. What's the fourth main type?
Cognitive therapies. Here, the focus shifts to your thoughts, your cognitions. The core idea is that our thoughts are the primary source of our psychological problems.
So it's not the event itself, but how you think about it?
Precisely. It's a directive approach. The therapist actively works with you to identify and change distorted or unhelpful thinking patterns.
What's that called?
The main technique is cognitive restructuring. You learn to spot your automatic negative thoughts and challenge them, like recognizing thinking errors.
Examples.
Oh, like overgeneralizing. Maybe one bad date means I'll be alone forever, or magnifying setbacks, failing one test means I'm a total failure and should drop out. Cognitive therapy helps you challenge those logical leaps.
How? Are there specific methods?
Yeah, lots of techniques, like questioning the evidence for the negative thought or decatastrophizing, asking, okay, what's the realistic worst-case scenario and could I cope with it? Sometimes even thought-stopping techniques.
Makes sense, and I hear CBT all the time. What's that?
Right, cognitive behavior therapy, CBT, is probably the most common form of therapy practice today. It's an integration. It combines the cognitive part, changing your thoughts, with the behavioral part, changing your actions, often through homework assignments between sessions.
So you challenge the thought and practice doing things differently.
Exactly. The goal is often to build self-efficacy, that belief that you actually can handle difficult situations and achieve your goals.
Okay. And you mentioned therapists often mix and match.
Yes, most therapists nowadays are eclectic or integrative. They draw from different approaches depending on the client and the problem. A great example of a successful integrative therapy is dialectical behavior therapy.
TBT.
Yeah, it was originally developed for borderline personality disorder, which is very complex. DBT skillfully blends cognitive behavioral techniques with concepts like mindfulness and distress tolerance. Been very effective.
Okay, that covers the main psychotherapies. Let's switch to that second major category, biological therapies. These are the ones prescribed by medical doctors, right?
Correct. MDs, usually psychiatrists. These treatments involve altering the body's functioning, typically with medication, but also sometimes with procedures. And they're widely used, even if we don't always know exactly how they work down to the last detail.
Let's talk drugs. What are the main types? For anxiety.
For anxiety, you often see anti-anxiety drugs, particularly benzodiazepines, things like Xanax or Valium. They work fast, bind to receptor sites for neurotransmitters that might be overactive, giving quick relief. But they carry a significant risk of addiction and dependence, so they're usually prescribed carefully, often for short-term use.
Okay. What about depression?
The most common are antidepressants, especially the SSRIs, selective serotonin reuptake inhibitors. Prozac, Zoloft, those are common examples.
How do they work?
They basically interfere with the reabsorption or reuptake of serotonin in the brain's synapses. This leaves more serotonin available, which is thought to help regulate mood. They take longer to work than benzos, maybe several weeks, but they're generally safer and less addictive.
Got it. What about bipolar disorder?
The classic treatment there is lithium. It's a mood stabilizer, helps even out the extreme highs and lows. It's tricky, though. The dose that works is often quite close to a toxic dose, so people need regular blood tests to monitor levels.
Why does it work?
Research suggests it might influence gene expression related to mood regulation, and it might even offer some neuroprotective effects, like preserving gray matter volume in the brain.
Interesting. And for psychosis, like in schizophrenia?
There we use antipsychotic drugs. The first generation, called neuroleptics, mainly worked by blocking dopamine receptors.
Right.
Newer ones, called atypical antipsychotics, are a bit different. They influence dopamine, but also serotonin pathways.
Are there side effects to worry about?
Oh, absolutely. And this is a critical trade-off. The older neuroleptics have a higher risk of tardive dyskinesia.
That sounds serious.
It is. It involves involuntary movements, often of the face, tongue, limbs. It can be permanent even after stopping the drug.
And the newer ones?
The atypical meds generally have a lower risk of tardive dyskinesia, which is good, but they carry a higher risk of metabolic syndrome. That means things like significant weight gain, increased risk of diabetes, high cholesterol. So choosing an antipsychotic often involves weighing these very different, serious potential side effects.
A tough calculation. Okay, besides drugs, are there other biological treatments? Procedures?
Yes, one is electroconvulsive therapy, or ECT.
ECT, that sounds intense, like in the old movies.
It has a very charged history, but modern ECT is quite different. It involves inducing a brief, controlled seizure in the brain. It's mainly used for severe treatment-resistant depression when nothing else has worked.
How is it different now?
It's done under general anesthesia with muscle relaxants so the person doesn't convulse violently. Often it's applied only to the right side of the brain to minimize memory side effects, which are still a concern but usually temporary. Hippocrates actually observed seizures sometimes helped melancholia way back when.
Wow, okay. Anything else?
A newer procedure is transcranial magnetic stimulation, or TMS. This uses magnetic pulses, not electricity, targeted at specific brain areas, often the left prefrontal cortex for depression.
Is it safer?
Generally considered safer than ECT, with fewer side effects. It doesn't require anesthesia. It's approved for depression, and a form called deep TMS is also used for OCD.
Okay. And then there's psychosurgery. That sounds drastic.
It is. Psychosurgery means irreversibly removing or destroying brain tissue to change behavior or mood. And yes, it has a dark history.
The lobotomy.
Exactly. We have to mention the prefrontal lobotomy, which was tragically popularized by neurologist Walter Freeman in the mid-20th century.
Tell me about that.
Freeman developed a technique using essentially an ice pick inserted through the eye socket to sever connections in the prefrontal lobes. He traveled around in what was called the lobotomobile, performing thousands of these procedures, often very crudely, with devastating results for many patients.
That's horrifying.
It truly is. A stark reminder of what can happen when enthusiasm outpaces ethics and science. Eventually, the severe side effects and ethical outcry largely stop the practice. Modern psychosurgery is extremely rare, highly precise, uses advanced imaging, and is only ever considered as an absolute last resort for incredibly debilitating conditions that haven't responded to anything else.
Right. That history really puts things in perspective. Okay, let's widen the view now to sociocultural approaches. Thinking about the person in their context, right? Relationships, community.
Exactly, because we don't exist in a vacuum. One common approach here is group therapy.
So therapy with other people who have similar issues.
Right. Led by a professional or sometimes a paraprofessional. There are real benefits. One is universality, just realizing I'm not the only one going through this. That can be incredibly powerful.
I can imagine.
Another is altruism. The chance to help others in the group actually boosts your own self-esteem. And you practice social skills in a safe environment.
Makes sense. What about family therapy?
Family therapy sees an individual's symptoms not just as their problem, but as potentially reflecting issues within the whole family system.
So the family is the patient, in a way.
In a sense, yes. Therapists use several key techniques. Validation is one, making sure every family member feels heard and their perspective is acknowledged.
Okay.
Reframing is another. That means shifting the definition of the problem from being located in one person, like Johnny is defiant, to being an issue the family is facing. How does the family handle disagreements?
I see. Takes the blame off one person.
Right. Then there's structural change, which involves trying to rearrange unhealthy alliances or coalitions within the family, and detriangulation.
Detriangulation.
Yeah, imagine two parents who are in conflict, but instead of dealing with each other directly, they focus all their energy, negative or positive, on a child. The child becomes triangulated, caught in the middle, maybe acting out as a result.
A scapegoat, almost.
Or sometimes a distraction. Detriangulation aims to get the focus back where it belongs, on the relationship between the parents, so they have to address their own issues directly.
Fascinating. Okay, shifting from the family to the wider community, there was that big movement, deinstitutionalization.
Yes, in the 1960s primarily. The idea was to move people out of large, often impersonal psychiatric hospitals and into community-based mental health centers. The goal was noble empowerment, prevention, better integration.
But it didn't quite work out as planned.
Unfortunately, no. The community support, the funding, the resources, they often didn't follow the patients out of the institutions. So, while it helped some, it also sadly contributed to the rise in homelessness and inadequate care for many people with severe mental illness. It's a complex legacy.
A hard lesson learned. Finally, within these sociocultural approaches, we have to talk about culture itself.
Absolutely critical. Most traditional Western therapies were developed with a focus on the individual autonomy, independence. That doesn't always align perfectly with values in more collectivist cultures.
So effectiveness can vary.
It can. This is why the field now really emphasizes multiculturalism and the need for therapists to develop cross-cultural competence.
And there's a term, cultural humility.
Yes, and it's so important. It's not about becoming an expert on every culture. That's impossible. It's about having a humble and respectful attitude, acknowledging that you don't know everything about someone else's cultural experience and being open to learning from them.
Does it help if the therapist and client share the same ethnic background?
Research suggests that clients often prefer it, and it can sometimes lead to lower dropout rates, especially for some groups like Black clients. But the key takeaway is that good, culturally sensitive therapy can be provided by therapists from different backgrounds as long as they practice that cultural humility. The ultimate aim is social justice, recognizing and addressing the impact of prejudice and discrimination on mental health.
Okay, let's bring it all together. We've talked about fixing problems, alleviating symptoms, but what about just general health and wellness? Can therapy help there too?
Definitely. We know mental health and physical health are deeply connected. Therapy can help people cope better with serious physical illnesses, cancer, heart disease, chronic pain, often by reducing the stress and depression that can actually worsen physical conditions.
Right. Stress impacts the body so much.
Exactly. And there's even a preventative angle. Brief psychotherapy integrated into regular primary care settings can be a cost-effective way to catch issues early, prevent disorders from developing, and help people change unhealthy behaviors.
And is there therapy focused specifically on boosting well-being?
Yes. There's something called well-being therapy, or WBT. It's a specific, directive approach aimed squarely at enhancing psychological wellness, not just reducing deficits.
How does it work?
It actively encourages you to sort of accentuate the positive.
Mm,
You might monitor your own happiness levels, keep track of moments of well-being, learn to savor positive experiences. The goal is to build up positive feelings and resilience to promote sustained recovery and flourishing.
I like that. Focusing on building the good stuff, not just fixing the bad.
Precisely.
So we've really covered a huge range today, from, talking about your dreams on a couch all the way to magnetic pulses stimulating specific brain circuits, all aimed at helping you, the individual, deal with suffering and live a better life.
It really underscores how modern mental health care is incredibly varied, complex, and ideally highly personalized. And that complexity leaves us with a final thought, something for you to really chew on. We talked about evidence-based practice, EBP, needing that integration of research, clinician judgment, and client factors like culture and preferences.
Right, that three-legged stool.
So here's the question. How much should a therapist stick rigidly to the published research findings, the empirically supported path, versus how much flexibility should they have when your unique cultural background or your personal strengths and values seem to point towards a slightly different approach? Where's the perfect balance between following the science and honoring the individual human sitting across from you? That's a constant negotiation in good therapy.